Hi followers of NeuroTakeaway, welcome back to the channel. Today we are going to reveal our fifth NeuroQuiz, and the diagnosis is thrombosis of the left brachiocephalic vein. To kick off, I would like to remind you that in 1966, Professor James Cimino from New York described for the first time the use of brachial arteriovenous fistula for hemodialysis. It was a very innovative procedure because it was relatively simple, with very few complications, durable and reliable. The problem is that we have to wait around 3 months for the fistula to mature. This maturation reaches its end when the fistula has a flow of more than 6 milliliters per minute. It has more than 6 millimeters of diameter and less than 6 millimeters of depth from the skin surface. During this time, we have to perform hemodialysis by the use of central vein catheterization, which is not exempt from complications, and one of the most frequent is the stenosis and/or thrombosis of the central vein. Well, to understand what's going on here, we have to remember how an MRA is performed. Here on my right, you have the planification of an arterial MRA of the head. We place a stack of slices or a volume, depending on if it is a 2D or 3D sequence, at the level of the head, but we use a presaturation band to suppress the flow that we want to abolish. In this case, we want to abolish the venous flow, so we place the band above the area that we want to study. Below, we have the images of our patient. On your left, you have the MRA, the arterial MRA, and surprisingly, we find flow at the level of the left transverse and sigmoid sinuses and at the level of the left internal jugular bulb. In the middle, we have the arterial phase when there is very little flow at the level, at these levels. And on the right, we have the MRA of the neck, where surprisingly we find dilation and flow of the internal and external jugular veins. Well, to complete our insight of this case, we have to remember venous anatomy. Here on the left side, you have a graph that represents this anatomy. We have the left brachial vein that continues with the axillary and subclavian veins that receives the flow of the external and internal jugular veins to form the left brachiocephalic vein, or the innominate vein, that unites with the other side one to form the superior vena cava. So the only place that we can imagine an obstruction to produce all this clinical radiological picture is at the level of the left brachiocephalic vein. This obstruction will produce that all this flow of the brachial fistula, remember that it is a high flow fistula of more than 6 milliliters per minute, will go up, reversing the flow at the level of the internal jugular vein and overloading the flow of the brain. Well, regarding the headache, the main mechanism is probably intracranial hypertension. As you know, CSF is produced at the choroid plexus and at the ependymal cells of the ventricles, and is reabsorbed mainly at the arachnoid granulations of the superior sagittal sinus and transverse sinuses. There is also some reabsorption at the spine, at the radicular veins of the spine, and at the lymphatic system. There is, now we know that there are lymphatics at the perisinal level in the head, and there is reabsorption through the perineural olfactory branches that transfers the cribriform plate. So when we have an obstruction, and not just an obstruction, but there is a reverse flow of a main vein as the internal jugular vein, there is an increase in the venous pressure and lower of the gradient between CSF and venous flow. So there is less reabsorption and an increase in intracranial pressure. Moreover, this intravenous hypertension may compress the lymphatics that surround these veins, increasing or decreasing the reabsorption. Another possible mechanism may be the compression of the trigeminal nerve terminals that reach the dura mater that surrounds the main sinuses of the brain. Well, the diagnosis was performed by subtraction digital angiography. You can see here on your right side that when we injected the right internal carotid artery, there is normal opacification, both of the arterial and venous faces. There is no contrast on the left side vessels. That may be due to a normal variant, but when we injected the left internal carotid artery, there is no opacification of the internal jugular vein and no opacification of the left sigmoid sinus. There is a reduced contrast opacification of the left transverse sinus, dilation of the supratentorial cortical veins, maybe due to collateral circulation, and normal enhancement of the right side veins. And here we have the confirmation of our guess. With the injection of the left subclavian artery on the venous face, you can see the obstruction, the subocclusive obstruction of the left brachiocephalic vein with reversal flow and dilation of the internal jugular vein. This flow goes directly to the intracranial compartment. Well, these obstructions of the brachiocephalic veins are not uncommon in hemodialytic patients. As you remember, we talked about the use of central catheterization at the beginning of this procedure. And regarding the solution of this problem, the easier way is to relocate the fistula, but if it is not possible, you can go to percutaneous stenting, or if not, to bypassing through surgical procedures. Well, we had no winners, but there were several comments, so I thank you very much for this participation. I hope you enjoyed this case, and remember that you never fail until you stop trying. So see you next week.